Okay, so to continue from last video where we talked about angina pectoris and some of its characteristics, symptoms, and a little bit of a differential diagnosis, in this video we'll discuss some of the cases that are a result of the progression of the case of angina pectoris. So as we already mentioned, angina pectoris translates to the squeezing of the chest, and it is pretty much a cardiovascular disease that mainly presents, in fact, conveniently, as a squeezing pain right in the middle of the chest. Now remember how in last video we said that angina pectoris is merely a symptom, and when we look at the causes of that symptom, or the etiology, better worded, we see that there is a clear correlation between angina pectoris and something called coronary artery disease. In fact, coronary artery disease is the most prevalent cause for the symptom of angina pectoris. In this video, we will hopefully shed some light on coronary arterial disease and maybe discuss in a little bit of detail the term myocardial infarction, which is the state where the lack of blood supply has exceeded the level of tolerance, and now unfortunately the heart muscle is dying. And hopefully this video turns out well. So if we exclude all other causes of chest pain that are not cardiac, for example, gastric regurgitation, esophageal irritation, or skeletal muscular chest pain, if we exclude all of these causes, then the term angina pectoris becomes almost synonymical, entirely synonymical with acute coronary symptom. So what exactly is coronary artery syndrome? More specifically, what's acute coronary artery syndrome? Well, as most of you probably already know, the coronary arteries are the major vessels responsible for delivering oxygenated blood to the cardiac muscle. So when the heart undergoes increased demand, say for example you go out for a run or a jog, or maybe you're working out in the gym, these arteries, they expand, or better worded, they dilate, allowing better blood flow to the cardiac muscle and allowing you to maintain this balance between removing the waste material that the heart creates and also maintaining a proper oxygen supply. Through some pathological mechanisms, this balance may get interrupted, leading to compromised perfusion. This condition is known as coronary artery syndrome. It can be either acute or it can be chronic, obviously. For the acute coronary artery syndrome, ACS for short, by the way, and for the sake of simplicity and since we're only discussing the terminology related to angina and acute chest pain, we'll only talk about acute coronary syndrome in this video. The final significant thing I can mention about acute coronary syndrome is its strong association with atherosclerotic disease. In nearly all cases of angina, the underlying cause of restricted blood flow is a progressively developing atherosclerotic plaque. You can associate that with possibly diabetes, metabolic disease, metabolic syndrome. Maybe your patient is overweight or suffers from morbid obesity. That would all leave them at a higher risk. And while alternative etiologies do exist, such as maybe an external compression by a tumor or more rarely a thrombotic embolism, these considerations are a lot less common, notably thromboembolism originating from the pulmonary circulation. Remember, we're talking about the left cardiac chamber. So the likelihood of a pulmonary embolism originating from the lungs, which are in constant motion due to the expansion of the diaphragm and the respiratory cycle, it becomes physiologically extremely improbable to have a embolism originating from the heart. It's not going to be called a pulmonary embolism anymore, I guess. It becomes extremely physiologically improbable. And while these scenarios are theoretically fun to handle, I guess, they should not be primary considerations when evaluating the typical acute coronary syndrome cases. So I guess that was my attempt at giving a general definition of acute coronary syndrome. As for the most common, and you can say also the most classic cases that fall under that term, ACS, you have four main scenarios. Well, there are actually three. The first one isn't considered part of acute coronary syndrome, but rather falls under chronic coronary artery disease. We don't really have to get into too much detail discussing it. It's, well, to put it simply, it involves a partial blockage of blood flow due to I need to stress this a little, a stable sclerotic plaque. There is no sudden blood clot lodging itself into it and causing a sudden blood flow obstruction, but rather just a steady, predictable reduction of blood flow that presents in a more chronic, less severe way. And that, you could say, is the reason why it's called stable angina. Now, the other three conditions, are the actual true forms of coronary artery syndrome, in some cases can represent complications or progression of untreated stable angina. These occur when chronic partial blockage is worsened due to various reasons. The most important are plaque rupture, thrombosis, both of which can lead to complete occlusion and leading to acute ischemia. Puts a lot of emphasis on the word acute, by the way. This is the most important difference between stable angina and acute coronary artery syndrome. Now, clinically speaking, there are many differences between stable angina and acute coronary artery syndrome, which makes it quite straightforward when you want to distinguish these two. We're talking clinically again. Stable angina has a distinct pattern. Chest pain is typically short-lived, usually less than 10 minutes, promptly relieved by nitroglycerin or rest, and occurs predictably with exertion or stress. In contrast to acute coronary syndrome, which presents with prolonged pain over 20 minutes, often at rest, and is less responsive to nitroglycerin, all of what I've just mentioned can really help you actually distinguish between these two conditions. Additionally, acute coronary syndrome is characterized by dynamic echocardiogram changes. For example, you can find NST segment elevation or depression in some forms of myocardial infarction, which we will discuss in more detail later on in this video, or maybe in the next video. Not actually sure. There's also the elevated cardiac biomarkers. All of these things are characteristic of acute coronary syndrome as opposed to the less severe stable angina. Well then, I guess I'll end this video here now. I hope I could give you guys a proper introduction into today's topic. And yeah, let's get on with the summary. So today we gave a short definition of angina pectoris. We talked a little about its etiology, and we mentioned the coronary arteries and how their blockage is the reason why these syndromes present. Remember that coronary artery disease can be chronic too. That is what stable angina is pretty much, as opposed to myocardial infarction and unstable angina, which fall under the acute coronary artery syndrome definition. Today we also talked about how easy it is to differentiate those two, acute coronary artery syndrome and stable angina, and I guess in the next video we will uncover acute coronary syndrome in more detail. And yeah, I guess that was it. Until the next video.